Good day, everyone, and thank you for joining us in today's presentation. I want to thank the HIMSS New York State and Greater Illinois chapters for co-hosting and presenting this presentation. I want everyone to know that this meeting is being recorded, and we will be publishing this on our YouTube link. And also want to let you know that the content that is being presented today is the opinions of those presenting and should not be taken as legal advice. Without further ado, I'd like to introduce you to our moderator, Tom Hallisey, who's going to take us through the initial content of this meeting, and then we'll get right into the presentation. So Tom, take it away. Thank you.
Okay, great. Thank you, Nick. Thank you all for joining us today. Welcome to our discussion of the 21st Century Cures Act, the rules it mandated, where we are now, and where we're headed. As Nick mentioned, I'm Tom Hallisey. I'm a longtime hospital CIO. I'm now with the Healthcare Association of New York State, where I've been about 4 years, and I run our digital health strategy, which amounts basically to working on our tech policy and regulatory efforts, as well as our technology educational efforts, such as today. As Nick mentioned, we also have an expert panel today representing all different areas from providers, vendor, HIE, legal expertise. We've got it all. So let me jump in and introduce our folks. We've got Todd Brago, President and CEO of HealthX, the regional HIE in Southern New York State area. Todd is a longtime health IT vendor, CTO, CIO, and now CEO. He started at HealthX in 2015 as Senior Vice President and CIO and was tapped for the CEO role in 2019, where he's led HealthX to be one of the largest publicly funded HIEs in the nation. We've also got Maria Phillips, Senior Counsel, Privacy and Compliance at Imprivata. Maria heads up the Privacy and Compliance program and is focused on enterprise risk management within the international landscape of digital identity solutions in healthcare. In her previous role, Maria served as the healthcare pillar for the CEO Action for Racial Equity Fellowship. Her work focused on developing large-scale solutions to the racial disparities that exist in healthcare within the US. And I apologize if you could hear the mayhem of the dogs behind me, the beauties of working from home. We also have Susan Murphy with us today, who is the Chief Experience and Innovation Officer at Northwest Community Healthcare, part of the North Shore Health System. Prior to this role, Sue served as the Chief Experience Officer for 8 years at the University of Chicago Medical Center. Sue was a strong leader with expertise in hospital operations, patient experience, staff development, and change management, as well as a long background as an RN and nurse leader. So with this wonderful panel, I first want to set the stage a little bit with a quick review, and I mean quick. I won't get into too much detail, as we will later with the panel, but just a quick review of the 21st Century Cures Act and what it has meant. For those who've read the whole thing, which probably only includes Maria on this call, the 21st Century Cures Act was actually intended to expedite the process by which new drugs and devices were approved, with easing requirements for those working with the FDA approval. It was somewhere well down in this document that the act defined interoperability and prohibited information blocking. And those are the terms we'll be talking a lot about today. So what the Cures Act did was it authorized the Secretary of Health and Human Services to identify reasonable and necessary activities that do not constitute information blocking. And what that meant practically was that CMS came out with patient access rules, and ONC came out with info blocking rules. And we might all remember that because it was, I believe, the day HIMSS started 3 years ago, 3 or 4 years ago. So the key touch points, I look at it as two particular aspects to these rules. One is all about enabling patients to access health information electronically and without special effort and through the use of standardized application programming interfaces. And the other aspect I refer to more as the B2B, the business to business, and that's ensuring that providers have the access they need to provide the care, but also that the payers and providers integrate, and their payer-to-payer integration, and even making it easy for patients and providers to identify providers within a plan's network. So all of these fit into these rules. So with the CMS interoperability rule, the aim was to promote patients' access to their health records and involvement in their care, with the bigger goal to free and share data, bring them more access and involvement in their care, empowerment, and do so, as I mentioned, with the standardized APIs. Whereas the ONC rules were more about defining the information blocking exceptions and updating the conditions and maintenance of certification requirements for the EMR vendors. And these are important aspects because the conditions of maintenance and certification is the only item really that isn't fully implemented and live yet. The API tools that must be in a certified EMR must be rolled out to customers by the end of this year. I don't know of any who haven't already done so, at least for providers in New York State. But there could be some, and that requirement is the last deadline coming up. But the ONC rules even get into the API fees allowable and an electronic health export. And as ONC defined information blocking, it's a practice that is likely to interfere with the exchange of EHI. And Maria will help us define EHI a little bit in a moment. But it also specifically stated that the actor, and in our case, the provider or vendor, knows that practice is likely to interfere. And so that's an important aspect as well to accommodate those who were concerned that there might simply be an oversight. I won't go through all the information blocking exceptions. I think we've heard about all 8 of those for some time now. We'll definitely get a little bit into, I think, the privacy and security aspects in a moment. But the key points being that within the certification, the APIs, the published standard FHIR 4.0.1 API that must be used will include the Smart Application Framework, includes authorization, and is really meant to build the security aspects in. And as I mentioned, even API fees and the fees you can charge are limited and set to be costs to develop and deploy those APIs and support the use of them. And this is important as well because the ONC and CMS certainly felt that one aspect of hoarding, if you will, the data was vendors charging huge fees in order to link to APIs. There's even, I just want to note, so it isn't forgotten, there's even a requirement that the certified vendors provide an export capability so that you could, in fact, export the entire data set to change vendors. How that would work, I can't imagine. I don't think that's been tried. But the idea certainly was that you're not locked in. As we all know, there's a lot more to being locked into a vendor than simply the data. All of that said, I want to now get to our panel involved. And Maria, I'd like to start with you. If you could discuss a little about your role at Imprivata and help us understand the definitions of information blocking, electronic health information.
Sure, thank you. So before I get started, I'm going to put some stuff in the chat for everyone so that you can follow along. And if you're having trouble sleeping at night, maybe you can go read these in your own time, but I wanted to make sure they're available for the team for later. So To answer your first question, what I do here at Imprivata is I head up our privacy and compliance program. That includes obviously a lot of security, as that's the other side of the coin. And I work on the enterprise as well as help with the product development lifecycle. So a lot of regulatory changes as they relate to technology fall within my wheelhouse. As far as your second question of information blocking, I think we had a general understanding of what that was from the original, but I wanted to make sure that we understand that the information blocking component this time around is that you either knew or should have known. And that I think Tom was alluding to a little bit that that's quite a broad spectrum definition. So if you or any other reasonable human would have thought that this applied to you, that this was information blocking, that you were in fact subject to compliance, then that really puts you in that bucket. So that's important to understand, because previously that's not the way that this worked, and certainly not for technology providers. In the healthcare provider space, that was pretty common, and we saw a lot of fees associated with this. And kind of, why do laws exist? And it's because people do things, and then this is why we can't have nice things. So one of the ways that this act addressed that issue is that you can't just charge people all of the time exorbitant fees, and you also can't act like you're not subject to it, or you don't have a duty to provide that. This act took the perspective that if you have the data, you kind of have a duty to the patients to give them that data if they want it. And of course, the exceptions. So I've put that list. Into Tom's point, we don't want to spend too much time talking about them, but Health IT does a great job of writing up what the exceptions are and when they apply.
Great, thank you. And Todd, I'd like to turn to you next to hear a little bit about the CURES Act's effects on a health information exchange and what you are doing and seeing.
Thank you. So thanks for the introduction as well, Tom. We move a lot of data. We're a huge data aggregator here in New York, Southern New York State. Our typical territory we cover is Long Island and New York City. But just to give some numbers out, we bring in over 330 million messages inbound to Healthix on a monthly basis, which is a lot of data flowing in towards us. It's not as large as the stock exchange, which is a little bit south to me here, but it's still a lot of data, a lot of clinical data. And we sit on 14 years of clinical records, really representing, in terms of an active patient population, about 25 million individuals. So it's a lot of data. This was a big sea change for us. We always had rules and regulations here in New York around letting patients know who's accessed their records. But now this is a really big push from the federal side, which I support, about empowering the residents of New York, in my case, with their clinical records. And we had to go through privacy committee meetings here at Healthix to really get what we call our participants to understand, get everyone on the same page that their data can be fully exposed for good reason. So if Todd Bragwa, if I want my records, I can see all of them. We talked through that from a legal perspective, a liability perspective, and just a duty perspective. And I just wanted to read for a second the Healthix vision. So we want to be that trusted partner, really sharing health information to improve people's lives. And that really speaks to our vision as to where we think this movement can go. So logistically, let me back up. Logistically, what we did is we got everyone on the same page, understanding where we wanted to go with allowing people to access the data. But more importantly, we focused in on a couple of areas. We focused in on this concept of the risk of harming the patients, and that was really important from a data supplier standpoint. There is certain sensitive data that may not be ready for a resident or a person to hear directly, and it could be an issue of how timely the data is. And since our HIE is very real time, there was some concern about if that could cause harm to a patient. without the proper engagement from a clinician first, that they get it through a HealthX source instead. So we talked about that. And then the other area we focused in on was how do we handle minor data? So people who fall in the age bracket of 10 to 17 as minors. Again, that's another sensitive area that we had to focus in on. We did come to an agreement that if the minor themselves, like my daughter who's 15, if she wants to put a request in, which she's more than capable, and ask for her data, she can do so, and HealthX would respond to that. But if a parent or guardian for a minor who falls in that age bracket of 10 to 17 does the same thing, we would not open up that data set to that parent or guardian. Now, obviously, if you're under the age of 10, then clearly that parent or guardian has full rights and access to have access to that data. So we would follow through on that. And then if you're 18, obviously, then you're an adult. So that just follows the normal procedures. So these are two areas we really had to talk through with our data sources, the providers and health plans that we work with, just to give them that level of comfort. And then from the HealthX operations standpoint, we also had to focus in on identity proofing. We want to make sure, since we serve such a large number of residents here in New York, that, you know, if Todd Rago asks for his records, we know it's Todd Rago. We can't just send them over to you, Tom, you know, if you were pretending to be myself. So we go through extreme measures to make sure that that's done. And also, when we work through a third party, we really make sure that their identity proofing is well understood by our staff, by our compliance staff and security staff. So we make sure that they have a proper way to identify that that person is who they say they are. And then secondarily, we look at their security posture. So if you look at the new apps that are, you know, like a patient portal app, we look at how is their app, is it secure? Is the transfer of data, is it going to be done securely from HealthX to this third party? Because I think, as you all know, once someone like HealthX moves that data forward into the hands of the resident of New York, into whatever application or even whatever format they want, it could be paper form, it's their responsibility, and HealthX is no longer liable for what happens to that PHI or that sensitive data from that point forward. So we really do try to make sure it's done securely with the proper identity proofing in place. And the last thing we focused on here in New York State is the education aspect. We wanted to provide, and we do this on our website today, education to the resident of New York to say, hey, we want to inform you, it's certainly within your rights, but be a little bit cautious in terms of who you want to partner with. If you're not coming to us directly asking for paper or something electronic, which we send just to you, if you want us to go through a vendor, you know, what are they using your data for? Are you aware of what you're signing off on? So it's a little bit of the Wild West out there today with different vendors, but we're not responsible again for this, but we want to educate the consumer whose data really belongs to, you know, in terms of some of the potential risks. So it's just kind of like, hey, take a look at our education. We want to just inform you. And then obviously we have to follow through. So if they want to post their PHI on Facebook, by all means, they can do that, right? And some people have done so, you know, and that's fine. That's your data. You can do what you want to with the data. But those are the three areas we focused on, you know, identity proofing, security, and the education component. And then again, with our data senders to HealthX, the risk of harm to the patient in terms of the timeliness of the data, because we do get it in real time, and then the minor data provisions around that. So that we had to really focus in on those. The last piece that I'll just say here for everyone is, I really believe in the vision for this. Obviously, I talked about the HealthX vision, but I do believe strongly that we will start to see, you know, consumers of the data actually impacting healthcare in a very positive way. I can tell you that the numbers are still low in terms of people taking advantage of this, but I know it's going to grow over time. At HealthX in the next, I think it's the second quarter of next year, we really plan on doing a big push in the New York area about making people aware of the opportunity. HealthX as a data aggregator, we can provide this service and give them access to their data. We want to empower people with their clinical data so they can take it with them to the clinicians that they see. And keep in mind, in HIE, typically our customers are the clinicians themselves. It's not so much the patient, but for those that may not be connected to HealthX and sending their data in and using our services, if we can empower the resident of New York to take their data with them, I think that'll help to change healthcare a little bit. The other really important piece is that feedback loop. And if people tell us, Todd, you just got it wrong. Like, I never went to that organization. I never had that encounter. I never had that lab test. Whatever it is, we want to have a strong feedback loop back to our senders of the data to make sure the data is accurate, and if there's any correction that needs to be made, that it's done. So I think that's a very important aspect, is this whole feedback loop. I don't think you see that in healthcare as much, but I think this providing access to clinical records to individuals allows for that feedback. And then the last thing on top of that is I do think engagement of the resident of New York is another piece I'm looking for, which is actively having them step up if they're willing to, and they look at their data and they say, you know what, my gender is incorrect, my race is incorrect, my ethnicity is incorrect. Public health in general really relies on the data in terms of the registration process when they go into that hospital or clinician and they say, Todd Brago, I'm a white, male, etc. They depend on that in for COVID, for monkeypox, for polio, you name it. They want to break things down and understand how these diseases are spreading in our community. So if we can get any additional corrections directly from the residents, I think that's really impactful to healthcare and how, at least from a public health standpoint, organizations are looking at the data and trying to make sense of it.
Absolutely. And I'd say that's a great note to lead us over to our patient experience expert here, because certainly CMS, part of their goal, or a big part of the goal, was not, as you mentioned, not simply access to the record, but an involvement in their care and engagement, as you mentioned, because of that access. So Sue, I'll turn things over to you to tell us about your work and the patient experience and how that's changing.
Well, thank you. Thank you very much. And great information from Todd, really kind of to tee up about what we want to do for our patients. So I think I'm coming from such a different venue from my other colleagues on this call, through the eyes of the patient and also the providers that give the care, more boots on the ground than all the other parts of it. So I think the part that I really wanted to stress is how important it is we always, when these type of initiatives come down, remember our true north, the patients that we care for every day. And how do we help them through things that Todd mentioned as far as education and understanding of what this information is. First of all, what does the act even mean to them? And what is it going to do for them? Because as we think about the world of consumerisms and how we're moving that towards healthcare, I think we still have to remember it's about healthcare and it's about the heart and about how are we bringing that caring way of being even to very important information about their data and their health record. Because it's very different than a credit report. It's very different than other data they get. It's their health information, which is personal and caring. And so I think it's really important as we continue down this journey and we think about education, how does our patient family advisory councils get involved in this in the very beginning? How do we create keywords for providers and other technology people to talk to patients about the why and what's important? And how do we take that fear away, as Todd mentioned, and not put risk to our patients for harm, but think about how this can help you in the long term with your care and for you and your family. So I really believe that as we continue, as I said, down this journey, it's important for us to really think about the voice of our patients, some key success stories when it goes well. How do we share those stories of success? How do we help people avoid any type of issues from data integrity or anything such as that? But then say, this is going to help you become healthier and cause no harm to you. So my real point is We can't forget about the voice of the patient. My role is inside a healthcare system that's extremely supportive of that. And I talk about this with other people and they look at me like, I don't even know what you're talking about. So how do we simplify it for our care teams in the best way, along with making sure we help them not be fearful, but really engage with this?
Great, thank you. And as I hear all of that, and as I heard what Todd just mentioned in his description of their work they're doing, I know one of the items that comes up pretty frequently is understanding the difference between exchanging data with a HIPAA covered entity and a non-HIPAA covered entity, and a patient accessing their data, for instance, from a non-covered entity, as Todd mentioned, other apps. Certainly, I hope Facebook doesn't become a specific healthcare app, but third-party apps that then want access into our provider systems. So Maria, maybe you could start on answering, the difference between working with a covered entity, provider to provider, for instance, versus a third party who is a non-HIPAA covered entity.
Sure. And that's something that I think is probably the crux of compliance here, is that, what our traditional notion and traditional sense of where there's a duty, where there's, sharing going on and who owns the data and whatnot, we've seen a really big shift. And we heard Todd mention this also. We had this previous notion of covered entities own the data. Well, wait a minute, whose data is it actually? And I think Sue would make that argument even before in the old days of our thought process. The patients own the data. And then we've seen that happen in the last 5, maybe 10 years. I would say 10 is a stretch, except for the privacy evangelists in the back. But we've seen that shift. And now with this new mentality and new perspective, certainly the regulators feel that as well, that the patients own the data. That created a very, very different compliance landscape. Now, patients are able to ask for their data from healthcare developers on the technology side, not just the covered entities. And when you have sharing, I think there's a distinction to be made for understanding where the data goes. And I frequently say, follow the data if you want to figure out what your duties are and where they fall. So for example, healthcare system 1 wants to share data with healthcare system 2 or a health information exchange. That's fine, you can do that. However, you don't have the rights to do that because you don't own the data. So without a notice and a consent to the patient and from the patient, you can't actually do that and in a compliant manner, right? You need to tell the patient and ask their permission to do so. And I think what I've seen a lot is what does that mean? And what if the patient says no, right? What if they opt out? Can I actually do that? And I think where I've seen most issues with this is when people first wanted to comply with interoperability, they built these mechanisms to do so, but they did them in an aggregated or bulk format. So if you're aggregating data, if you're bulking data, if you're doing bulk uploads, you're not able to discern on the patient level, and you're certainly not able to discern on the elemental level. So maybe you have to share XYZ elements, but not 1, 2, 3 elements. And what does that mean, right? And the privacy by design concept dictates that you do minimum necessary data, right? So you don't just share everything because you wanted to. You share what you are supposed to share for the purpose of that agreement, for the purpose of that relationship, to the extent that you have consent to do so. And that has created a lot of challenges for organizations. So that's the first kind of level. The second level is if the patient is asking for something to share with someone else. If you have to share with a third party, generally, when you make that decision as a healthcare provider, you've made that decision with a lot of diligence. You've gone and you vetted those vendors, you've obtained the necessary evidence from them to make you feel comfortable that they're going to do with the data what you want them to do. And we've seen consumer privacy laws dictate this, right? We have the security rule, which, even though it's 10,000 years old, it still tells us you have to meet certain security safeguard rules in order to process protected health information. Well, you can do that as a provider when you push down those obligations onto your business associates. It is an entirely different ballgame when the patient is dictating that relationship and they say, hey, I've got this app that I want you to put my data on, and you don't have necessarily the right to say no because that app wasn't vetted for security and privacy rules. And what if you have to build some sort of API with that app in order to share that data, right? It's not just a bulk download or a bulk upload. You're actually letting them access your infrastructure. What kind of risk does that present to you? And when, where are the lines? Where can you say, no, this is a risk, not just to my organization, but to every other patient whose data I hold in my organization? But then, you run the risk of information blocking, right? So you have to really balance these depending on where the data is going, where is it coming from, who's the asker, and what data is being moved around.
And yes, thank you for that. And, I'm thinking of all the different aspects to that, one of which was, in a Q&A, CMS specifically said, and Todd, I think you mentioned this the other day, even if the patient wants you to send the file, a file in text, unencrypted over email, you have to do it. And so a key here would two aspects, I think I always point out. One is educate, as Sue mentioned, and there are tools to help you do that. You're welcome to educate your patients, who your users of records. You're just not allowed to stop their access, but also be proactive then, and come up with tools of your own so that when the questions come up, you can try to guide them to tools are safe. But yes, to Maria's point, in the end, the patient, it is the patient's choice. So along those lines, what are any of you seeing for real world examples? Are you seeing any yet for using FHIR for this direct data element access, as Maria mentioned? Because one of the real keys here in this change by using an API is we can get down to specific data element interchange rather than some big CCD.
I just want to add on to what you had to say about education too. Excuse me, I'm sorry. Education does not change behavior though. And education does not equal understanding. So I think just one part too, Tom, that I was thinking about is how do we validate the understanding of the education that we give to our patients and providers around this? Because we feel that we walk away and we check it off our checklist. Yep, they're educated, they get it, and they walk away with not a clear understanding. So I think, how do we put in parameters to understand their understanding of the education and what it means to them? I just didn't want to forget to say that.
No, that's a great point, because I think in my head, I was thinking check the box. So thank you for that reminder.
Yeah, and I think, from a health tech standpoint, we're in the business, I kind of see it as wholesale and retail, right? We're in the wholesale side of the business, which is we aggregate lots of data. We typically make this available to the clinicians and the care managers of the world, but not the patients directly or the residents of New York in our case. So this is a game changer, and we really don't want to be in that space, to be honest. We don't want, we're not that large an organization to take millions of or hundreds of thousands of calls a day saying, what are you doing with my records? But so we partner through our partnerships. We want to make sure we have good partnerships that do handle the data properly, that do have the proper security protocols in place. So we kind of go through our internal vetting on behalf of residents of New York to say, hey, we're not requiring you to get your data through these methods, but here's some apps that we support, and we have that FHIR API exchange built. However, but we also, our lowest common denominator, and we've done this numerous times, is we've actually printed out, hundreds of papers, and we've had to mail them. We've done it through like a FedEx where we can track it, that it makes it to the person who we're sending it to. But, we've done this. We've gone to the lowest tech possible, version to get these records out into their hands at their request. But of course, our choice is dealing with such a large population is, can we automate this? Can we do this in a manner which is still very secure and the privacy is kept in mind? And that's what we want to do to kind of protect our company, but also to protect the residents who are asking for this data, because they may not fully understand what happens if that unsecure email gets hacked and what could happen to their data, right? So we as technology experts understand the pitfalls to a lack of security, and we've had experienced some of that. So we will try to do our best to protect the residents from that.
Thank you. Yeah, and along those lines, I know that last year, I think it was last year, there was a study done that looked at a bunch of healthcare apps currently downloading healthcare data, again, non-HIPAA covered entities, and found that 79% of them had been found to sell or share patient data. And I can't remember off the top of my head what the percentage was, but I think roughly half of those selling the data also didn't even tell you they did it in their privacy statement, which of course is against FTC rules. But those are the only rules we have now to protect them. So I don't know if anyone has seen, Sue, have you seen healthcare apps or providers in this space yet doing things where we're combining for the patient data from 2 or more providers? Meaning in a single app, I can begin to pull my record together?
I have not. Thank you for asking. I've not seen that as of yet, but I will tell you there's a lot of curiosity behind it and what that's going to look like in the future of the apps. Because I do think still at this point where I'm living in my geographic area, it's still just that, is the app safe, more than that thinking about pulling apps in. And there's a lot of question around safety. So I haven't seen the apps pulling them together. I have seen it through things such as Epic My Chart and how they get information to other things. That's been pretty robust, but not the apps.
Thank you. So I have a specific question that was actually asked of me, and that is, can a provider meet the regulations for having patient access by using, Todd, for instance, a health information exchange or outside vendor other than their EMR portal for the FHIR patient access, for the electronic access that is required? I'm not sure I asked that question particularly well, but.
So you're asking, can a hospital system rely on an HIE to kind of serve this?
Yes.
I think it's a partial yes. I mean, yeah, as a resident, you can go to, or as a patient, you can go to whomever to ask for your records if they have it. So Healthix is one of those BAs, business associates, that actually has a lot of data on behalf of hospitals and other types of organizations in healthcare. But that doesn't preclude them also going to that hospital and saying, I need my data directly from that organization. So I don't think it's an or situation. I think it's more of an and. That we've never objected, and for many years we've offered, from a Healthix standpoint, to specifically the hospitals that have those patient portals. We say, look, have your patient portal where you do scheduling and all this other good stuff, which we don't want to have anything to do with and we can't provide. But if you want to put a button in the lower corner says get your statewide records from Healthix, we're happy to be there. And we've had a few organizations that have taken us up on that. The challenge that they run into, to be honest, is if they get calls on data which is not supplied by their organization, they have trouble answering those questions, because they're like, they represent hospital A and they say, wait a second, I'm getting a call now about hospital B. I have nothing to do with hospital B. And so we at least have an informal arrangement where if they get those types of calls, they contact us so we can then help them get those answers, or at least take over that interaction with the person who's calling to help them. And I think that's the real challenge for a data aggregator such as an HIE is, we get data from all different types of sources. And so how do you deal with the questions or the potential confusion that could come up from providing an aggregated record to the person who's requesting it. So, and it's also, keep in mind, the way we get the data is not very user friendly always. A lot of codes, a lot of abbreviations. And so I think a lot of future work needs to take place in the industry about, the whole open notes, and making notes. It's very similar to that, right? How do you make now a clinical summary user friendly to the patient? Because they're typically directed towards other clinicians who understand the inside speak, of healthcare. So I think that's definitely a challenge, and that is where we've been getting some questions as well for what we've done so far.
And I think that's a great point, because I think that was specifically stated as the hope by HHS when these standards were opened up, which would be next year theoretically, and the private marketplace can get involved, that there would be apps that do that. Because for those of us who go back a ways, boy, it's quite a while back that CMS created the blue button. And
Right.
For those not familiar with it, it's really the FHIR API, the same idea. And you could take an app. Boy, I think 10 years ago I tried this. I had to test on someone else. I certainly wasn't old enough. But through Medicare, I was able to show you could download your whole record. But to your point, Todd, there was nothing you were going to do with it. It was a giant mess of data on your phone that was completely useless. And now, as we just heard, we're still in a case where I can get my information from maybe my primary office, but can I link it to the cancer center I went to, or the cardiology specialist? And that is the goal for this marketplace. And I know we hope to get to that a little in a moment, but I first wanted to throw out, as we look at some of the examples, like a favorite example of mine that still isn't running here in New York State, but I believe is in Illinois, is a direct link to the prescription drug management database for state. And, a FHIR API directly out, now that every vendor has to meet those standards, to pull that kind of information in directly is a great example. And here in New York, there were immediate concerns at the state level about security and privacy. And so maybe we want to talk a little bit more about the security concerns and how they are and aren't addressed in these standards.
I mean, I have a very, I guess, jaded perspective of the FHIR rules. I don't think they're enough. And I think they're pretty easy to meet. And I don't think their rigor is going to actually address the thing that they want to address. So I think they need some fluff. They need a little bit more of TLC before they meet standards. Like I mentioned earlier, just because they meet the FHIR rules doesn't mean they would meet the diligence standards that healthcare providers generally put on themselves and their vendors. So that's number one. Number two, I think there is a lot of, unfortunately, a domino effect here of we have this one act that we're talking about today, and maybe we comply with that, but what implications does that have on our compliance with the FDA? What kind of, impact does that have on our compliance with all of the other federal regulations that we are subject to? So it is a balancing act to provide interoperability and access and whatnot, but also to make sure that you're not doing that at the cost of some other measure. So with the drug piece, and certainly also with behavioral health, right? We have special rules around those. So FHIR is not enough. We have to also think about meeting those requirements. And I think the act does a good job of saying, hey, this isn't going to, no state act can supersede this one. And this one is also not meant to supersede any other federal regs. So to the extent that it impedes compliance with the other ones, that's kind of where the barrier is. So you certainly are not in that position, right? If you can say, if I do this way to meet, the CURES Act, then I may be violating FDA regs. Nobody is asking you to do that, right? Nobody would fault you for saying I have compliance obligations elsewhere. But from a utopian standpoint, I think there is a lot of opportunity here that would save from an operations standpoint on kind of all realms. We know now that doctors' offices, just offices that are part of healthcare systems, right? The primary care extension of a hospital is spending anywhere from 45 minutes to an hour and a half per prior auth, right? And that is an egregious waste of time and a very, very, very big burden on our healthcare providers for something that is otherwise extremely administrative, right? Most of that time is spent on hold. It's not actually doing any work or exchanging any information. So the future state of this is that you get an instantaneous prior auth. The same thing that we have with tier 1, tier 2, tier 3 drug classes. You have to call and make sure that those are approved before you prescribe them. We have, here in Chicago, our big healthcare systems have entire departments that are dedicated to this task alone of just calling insurance companies and verifying drug coverage prior to submitting the prescription. All of these times can be eliminated by this interoperability future state between technologies. You can get instant approval, instant prior auth, instant verification of coverage. And that goes, not just to drugs, but surgeries and other procedures. So there is a big opportunity for helping to decrease the burden on healthcare organizations today that I believe, and this is my personal opinion, is nonsense. It's just nonsense.
And just so you know, there is, they were announcing it just this week, the Sequoia group, there is a pilot going on to do just that, to use FHIR to handle prior auths. I can't remember the health system offhand, but that's a great start because they've been looking at the standards for that for some time and the individual data elements to exchange, but to actually be piloting in the real world is a great start.
Absolutely.
Any other thoughts? Go ahead, Sue.
Oh, I'm so sorry, but absolutely. And Maria, just think about what those people that are bogged down with that could be doing differently for patients. And that to me is where we are dealing with staff shortages and all the struggles in healthcare. Until we start looking at the value of what people are bringing, we're still going to have that problem. So I think what you have to say is so important, not just for the nuts and bolts of that happening, but for healthcare overall, to make sure people are doing what they can for patients instead of bogged down for 45 minutes on hold. So that's really important.
Tom, I think you actually mentioned something about the ability to take from electronic health record system and fully download the records. I think some of what's in the CURES Act is really about freeing up the data, not just for the direct benefit for me as that is my data, it's a Todd Rago, but to get these vendors out of this mindset that if they control the data, they control the marketplace. Right. So there's this whole, and I know we're all alluding to it, and that has been a big struggle from an HIE standpoint for a long time, because our business is data aggregation. We want to work with the EHR vendors to aggregate data. And I would say the majority are okay with that, but there are a few that are not. They see this as their hold on the marketplace to hold on to that data as their major asset. And honestly, it's not their asset to hold on to. It's either the provider asset, whoever's using their application's asset, or it's the ownership of the person's data, whose data it is. It's just we have to free that up. So I think what I'm most excited about is how this is freeing up the data from the data that's been held captive by the vendor community in general. And I think through doing that, we'll get the efficiencies that we're highlighting now on the call today around the operational benefit as well as the patient benefit to get these decisions made in real time instead of being dragged out because people just don't want to give that data up. So I think that's a huge benefit to what's happening right now.
Absolutely. That's a big piece. And I'll say it even though I shouldn't, because I work at the Healthcare Association and represent the health systems, but it wasn't just the vendors they were pointing at.
Right.
And that's an important note because patients, no matter how big your system, they cross into other systems. And that's a very key aspect to all of this. that I know gets brought up. And I've been negligent in mentioning, anyone, please feel free to ask questions, type them in at any time. I know we've only got about 10 minutes left, so feel free to do that while I ask a question that was important to me to ask, which was, we talk about the security, the privacy, all the potential issues, but as you look several years down the road, where could this really lead? We solve all the problems. Everybody's educated, security and privacy. Maybe we even have a great privacy law nationally. Who knows? But however we've done it, all that's working great. Where can this lead us? And Sue, I wanted to start with you from the patient aspect. Like in the perfect world, years down the road, what might they be looking at?
So I think to me, my first thought is truly patient-centered care. That the patient is in the center of the care, not the data or the nuts and bolts behind it, as I said before. So I think down the road, years from now, as we continue to think about healthy way of being and our health aspects, not just what's our data that's showing us that what we need to improve, but also how are we helping people through this data, through the data sharing, to get the very best care to keep them as healthy as they can, both mentally and physically, clinically, and your overall well-being. And it also, though, to me, we can't not think about the providers and people that care for the patients, what it does for them. Because what I hear in my rounding is the alignment of employee engagement and patient experience is so key that if we can do the things you just mentioned, Tom, what that would mean for those that are caring for others to spend that time to care for them, not just care for their data.
That does sound nice. Todd or Maria, your thoughts?
Go ahead, Maria.
I'll let Todd go first. I can
Oh, my goodness.
see you itching to say something.
I'm typing in comments in the chat window here to people who are commenting. I don't know. What I think is what is still missing, to be honest, and this kind of underpins the whole movement. We need to get people engaged. Like I'm very engaged when I go to buy a house, right? I know what my credit scores are. I know what my, I follow my everything on the financial side. It's the same thing with healthcare, right? You have to kind of get on top of your records. Now, if you're a healthy individual, what's your incentive to actually be on top of your healthcare records? There's probably zero incentive. You have zero interest in looking at them. I mean, maybe if you're into working out, there's a certain element of health data that you really want to track for your own well-being. But I think we have to find a way to I don't know how to put this, make this more attractive for people to get engaged. Because I think they're obvious. It becomes very obvious when you're sick or when your child is sick or your parent that you're trying to help out with healthcare. That's an obvious use case, but I think we need to refine our use case, because without getting people more engaged, the benefits that we're talking about on today's call are kind of lost, and it's going to take many more years to build up that benefit proposition. So that's really what I'm trying to figure out, is how do we engage the population as a whole a little bit more, because still when you look at the percentages, they're kind of low. Meaningful use, when it first rolled out, they had like a 2%, went up to 5%, maybe it's a 7% in terms of their target, what they needed to hit in terms of people looking at their records online through a portal. We need to be in the 20s to 50%, if we really want to see a movement behind this. And I think if we as technologists and vendors in this space, if we make it easier, I think we will see an uptick in that engagement, just because it'll be user friendly, it'll be easier to get access to records. So that's the piece of the equation I'm focused on right now. How can we make it easier? How can we provide the awareness? How can we give them that education? But the stickiness is still missing. Like there's nothing I can give away except for the clinical records, right? I'm not gonna hand out a free drink or something, So we have to find a way to make this sticky, where they're gonna want to come back. And I think if we look at the health plans in particular, I think they have some of the tools in place, and they're always struggling with this. How do we incentivize Todd Rogwood to work out more, to stay healthy, right? So I think maybe we can take the lead with some of the health plans that are leaning into this problem.
Well,
maybe. Yeah. Go
I'm
ahead.
sorry to jump on that though, it
Yeah.
leads to my pie in the sky view of this, which I think was, CMS's dream as they put this out. But the answer to me is obvious, although not easy, which is simply more integration. And I look back I recall having a cell phone that I had to carry as a hospital administrator on call. So when I went for a run, I had to have a cell phone. Now I'm dating myself here, but it didn't have anything else on it until I found one that could also play music. But then there was a separate Palm Pilot for your contacts. And if that isn't idiotic, I don't know what is. And yet that's kind of where we are here. So, I could be running with a Fitbit on, and I'm using, a special app to trail run, which I sometimes do, or whatever it might be. Or, lots of folks are tracking the diet and all kinds of other things. So it's not just the chronic condition people, to your point,
Right.
the obvious case now, but what happens when we put it all together? And to me, that's CMS's dream. When I have an app marketplace that's like the iPhone app market, where the integration and the security, theoretically, again, is all taken care of. And so I can plug and play these pieces so that I can take the app off my iFit, and I can take the app that integrates into Epic or Cerner and gets those aspects of my care. And I can pull this all together without a PhD, because frankly, even now I can't pull it together, and I've tried just for talks like this to see how practical this was, and it simply isn't yet. But my pie in the sky is that it will be when we get those integrations correct, people will see the real value in this. But it's got to be easy.
My pie in the
Go ahead.
sky is even one step
Go,
higher than
go
yours.
higher.
I'm going to take it to like the utopian level. One of the things that I think see a lot of CMS initiatives trying to address is the fact that we don't have a tremendously great continuity of care. This is one big way to address the continuity of care issue. We have seen, I kind of put in the chat earlier a plug for value-based care. And while we talk about value-based care mostly in kind of the billing component, right, and having healthcare providers and suppliers and payers and whatnot incentivized for outcomes, there's no reason why this should be any different. I think this is one piece that contributes to that value-based care conversation of we have people who are not able to get adequate health care because of the fact that their providers are limited in the knowledge that they have about their history. You can't take a symptom in a vacuum and think that that is an adequate way to diagnose a patient. You can't. And so when you take all of these kind of pieces that CMS is trying to put together, I think this is one way that they can be aggregated to say, you know what, we can actually help influence patient outcomes. We can decrease the cost to the healthcare system that is currently just overburdened with administrative issues. We can make payers happy because they don't have to deal with as much paperwork, and they will have better outcomes and won't have to pay for as many emergency room visits. And we will take the burden off of the hospitals for having to take people in for chronic conditions, which have a lot of preventative care initiatives possible, right? So, and then back to the patients who will just have better healthcare outcomes, which in the end is why we care about any of this in the first
So
place.
you sound like you should be at CMS and HHS where they started this. I noticed we only have 2 minutes left, and there are some questions I want to try to get to, see if I understand them, these questions correctly. One was a great question. What are the greatest ROI use cases regarding patients' access to their data currently? Has anybody heard of, I know I've seen studies, I can't think of any off the top of my head with all the new digital health vendors out there, where a patient's app.
Did we lose Tom?
I think we lost Tom, and we are at time, and I want to make sure that we are respectful.
He's coming back.
Tom, I lost you for a second.
Oh,
We
Am I
couldn't hear your
back?
question.
oh, wonderful. Oh, well, I was asking about there was a question on here about the ROI for a existing case regarding patient successfully accessing their data and using that access to improve their care and outcomes.
I actually have a really old study, which I'm going to throw in here, which is from the NIH, not our country, but
Yeah.
this is my diplomatic way of throwing this in here. This is one of my favorite studies, so I'm throwing it in here.
That'd be great. And I think stories are powerful as we move on.
Absolutely. And yes, as you mentioned, we're at time, but there's also a question about labs. And really, it seems to me the question is that they weren't part of meaningful use. They don't have a certified record. We're experiencing that with long-term care, with home health. I know I, for one, am pushing that funds be made available. I'm pushing every aspect we can to make that happen, but it's certainly understood that there's a glaring hole still as we move forward. And I think groups like HealthX, I think our HIEs are helping us with that.
Yeah, and I'll put a plug in for New York from a policy perspective. The State Department of Health has really required many organizations, hospitals and others to actually send their data to an HIE such as us. And it's obviously in support of public health initiatives, but again, it's got that broader focus as well, which is empowering the clinicians to better serve the patients. So just kind of keep that in mind. We've got a multi-purpose, hopefully benefits on all fronts to come of this. But some states have no requirements in place, and it can still work. But then you've got the competitive nature of organizations that kind of kicks in, and they want to control the data. So I'm kind of happy to see this federal movement, because that's above everything, and that can kind of help really move the needle and move things forward.
And I apologize, it doesn't seem we can get to all of these questions. There was one asked, will the links be available? I know this will be recorded and accessible, the session, so you could get them that way, but I'll also pester the HIMSS staff later to see if they can be pulled off of there and sent out in an email to all those registered. Can't
Perfect.
guarantee it, but or Nick, can we do that? Well, I won't call him out now, but I'll get him later.
Yep, we can make that happen. We can
Great,
make that
thank you,
happen.
Nick. Wonderful. So yeah, to be respectful of everybody's time, I want to thank you all for joining us, and really thank Todd, Sue, and Maria for expert information for an hour plus here.
It was a lot of fun. It was my pleasure. So thank you.
Thanks for having us, and thanks to all the
Gave me a
attendees.
reason to put on a blazer, right? So
Thank you.
My absolute pleasure.
right.
Thank you for including the patient's voice.
Absolutely. Thank you. Thank you all.